In this section, we will discuss the diagnosis and therapy of diseases of metabolic and storage pathways. So there are many different pathways that we can discuss as far as genetics are concerned. The nucleic acid metabolism pathway, amino acid metabolism, metabolism of sugars and complex carbohydrates, lysosomal storage diseases, LPL and LDL mutations, and bile metabolism. Let's begin with nucleic acid metabolism. Remember, the goal of this pathway is purine catabolism and salvage. One of the key enzymes in this pathway is hypoxanthine guanine phosphoribosyltransferase transferase. This is a key enzyme that is involved in converting guanine and hypoxanthine to GMP and IMP, respectively. So what's the disease that's associated with this enzyme? It's Lesch-Nyhan syndrome. So this is a loss of HGPRTase, and it's inherited as an X-linked recessive disease. What are the characteristics? You see excessive uric acid production and hyperuricemia because of the lack of ability to metabolize purines. You also see mental retardation, self-mutilation, and gout. As far as amino acid metabolism goes, remember, again, the goal is to metabolize protein building blocks, or amino acids. And there are various pathways of breakdown that we see. Because of the various steps, there are also various diseases. And here we see the breakdown of phenylalanine into fumarate and acetoacetyl-CoA. There are different types of disorders that can result from mutations along the pathway. They include PKU, tyrosinemias, and alkaptonuria. So with PKU, or phenylketonuria, the incidence here is about 1 in every 15,000 live births. The defective gene is phenylalanine hydroxylase, which is found on chromosome 12. The deficiency is that you cannot convert phenylalanine from the diet into tyrosine. Because of that, patients build up phenylalanine, they have an excess, and tyrosine becomes an essential amino acid. They can't get it from the phenylalanine. What's the phenotype? Mental deterioration, hypopigmentation, a mousy body odor in the homozygotes. Remember, this is an autosomal recessive disease because it's a loss of function, right? So the treatment here, remove phenylalanine from the diet, supplement tyrosine into the diet. And all states at this point screen newborns for PKU. Alkaptonuria is caused by a deficiency of homogentistic acid oxidase, which results in an increase of homogentistic acid in the urine. Because of this increase, what we see is darkened or blackened urine, so you'll often find a baby's diaper to have this dark color to it. It's largely harmless, though adults can have darkening of extracellular matrices and arthritis. It is also an autosomal recessive disease. Maple syrup urine disease is caused by branched-chain ketoacid dehydrogenase deficiency, and it leads to accumulation of branched amino acids such as isoleucine, leucine, and valine. It's characterized by a urine that smells very sweet, almost like maple syrup, hence the name. Severe neural damage and metabolic decompensation can also occur if it is not treated. A couple of other amino acid metabolic deficiencies. One is Hartneff's disease. This is autosomal recessive, and it involves the transport of neutral amino acids across both intestinal and renal epithelial cells. The symptoms of Hartneff's disease actually mimic pellagra because of a tryptophan deficiency. And like treatment of pellagra, you can use niacin to help these individuals. Cystinuria is an autosomal recessive disease characterized by the inability to absorb cysteine and basic amino acids across intestinal and renal epithelium. This can lead to the development of cysteine stones, which show pictured here. So if you see a picture of these hexagonal stones on the boards, think cysteine, think cystinuria. It's highly specific. Now on to sugar metabolism. We've all memorized this pathway before in our biochemistry lectures. This is glycolysis, right? We have glycolysis, we have glycogen, we have the pentose phosphate shunt. So, going through this diagram, glycolysis allows simple sugars to be converted to usable energy, right? Defects in glycolysis are usually rare. When they are found, they're autosomal recessive and they cause hemolytic anemias. Sugars that are converted to glycogen storage we'll talk about in a little while. There are several different glycogen storage diseases. Let's focus in on that middle pathway, the pentose phosphate shunt, or the hexamonophosphate shunt. This exists for a couple of reasons: to generate NADPH for reduction reactions, and to convert pentose phosphates to ribose 5-phosphate for nucleic acid biosynthesis or glycolytic intermediates. Now, what's the one disorder that comes to mind when you talk about the pentose phosphate shunt? G6PD deficiency, right? Glucose 6-phosphate dehydrogenase is an enzyme that's necessary for replenishing NADPH, for detoxifying free radicals and peroxides, things like that. Now, this deficiency, G6PD deficiency, is very common, especially in African American males, affecting 1 in 10. It is inherited as an X-linked recessive phenotype. Decreased NADPH ultimately leads to hemolytic anemia, which is what you see symptomatically. These patients are extremely sensitive to oxidizing agents, so as far as drugs go, you have to think about sulfonamides and primaquine. Another interesting oxidizing agent is fava beans. So if you see fava beans anywhere in your question on the boards, think G6PD. A couple of other carbohydrate metabolism or sugar deficiencies are galactosemia and fructosemia. Now these two are great to compare and contrast, and for that reason the boards like to question on them. So you want to know the differences and similarities between the two. So galactosemia or galactosuria, like the name suggests, is an increase in galactose in the blood and in the urine. Fructosemia is increased fructose. Now galactosemia can cause cataracts because of the aldose reductase deficiency. In fructosemia there is no cataract formation. Galactosemia, we have galactokinase trapping galactose in cells by phosphorylation as galactose 1-phosphate. Fructosemia, same kind of mechanism. Fructokinase traps fructose in the cells by phosphorylation as fructose 1-phosphate. So again, we see similar mechanisms there. The enzyme deficiency in galactosemia is Gal1 uridyl transferase. In fructosemia, it's aldolase B deficiency. So with the Gal1 uridyl transferase deficiency, the normal job of that is to convert galactose 1-phosphate into glucose 1-phosphate. And if it's deficient, then the galactose 1-phosphate accumulates in the cells and produces the symptoms. Similarly with fructosemia, if the aldolase B is not there, then we get a buildup or an accumulation of fructose 1-phosphate and symptoms are produced. Galactosemia produces symptoms and problems in the liver and in the brain and in other tissue. Fructosemia is specifically for the liver and the kidney, so that's another difference. For galactosemia, symptoms evident while on breast milk, so early onset of symptoms after birth. You start to see that galactosemia symptoms take effect right away. Now with the fructosemia, symptoms are not evident while on breast milk, so it's a late onset after birth. What you'll start to see with galactosemia is hypoglycemia, lactic acidosis, jaundice, and mental retardation. With fructosemia, you'll see hypoglycemia as well as lactic acidosis and jaundice, so those are similar. But with fructosemia, you see proximal renal tubular disorders resembling Fanconi syndrome. Now, how do we avoid these? Galactosemia, you want to avoid milk and milk products that contain galactose. For fructosemia, you want to avoid honey and table sugars, which contain sucrose. Now, glycogen storage diseases. These are defects in synthesis or catabolism of intracellular glycogen. Symptoms vary based on pattern of expression of the involved enzymes. These include von Gerke's disease, Pompe's disease, Cory's disease, and McArdle's disease. Notice this is type 1, type 2, type 3, and type 5. There actually are a type 4, type 6, and type 7, but these are rare and not usually tested on the step exams. So let's get some of the basic characteristics, some of the need-to-know facts about each of these diseases. Von Gerke's disease is type 1, and it's glucose 6-phosphatase deficiency. What you see in these patients is severe fasting hypoglycemia and increased glycogen stores in the liver and renal tubules. Why? Catabolic defects. They can't break it down, therefore they become hypoglycemic. You also see failure to thrive in infants. Type 2, or Pompe's disease, is an alpha-1,4-glucosidase deficiency. It's also known as acid maltase. This is a lysosomal enzyme, and patients with this defect have problems such as cardiomegaly and muscular problems. The common form is lethal in childhood. Cory's disease, or type 3 glycogen storage disease, is also a glucosidase deficiency, but this one is alpha-1,6-glucosidase deficiency. It's also known as a debranching enzyme. Here we see hepatic glycogen dominating the clinical picture, and similar to von Gerke's, fasting hypoglycemia and failure to thrive. McArdle's disease, or type 5, is a deficiency in glycogen phosphorylase in skeletal muscle, which leads to increased glycogen stores within this muscle. What you see in people with McArdle's disease is cramps and myoglobinuria following strenuous exercise. It usually has an adult onset, and people with this disease have a normal lifespan. We also have other lysosomal storage diseases. These include the mucopolysaccharidoses, Hurler's disease, and Hunter's disease, as well as the sphingolipidoses and sulfitidoses, including Tay-Sachs disease, Gaucher's disease, Niemann-Pick disease, Fabry's disease, Crabbe disease, and metachromatic leukodystrophy. So for the mucopolysaccharidoses, we have Hurler's and Hunter's disease. Both of them have to do with this iduronate. With Hurler's, it's a deficiency in alpha-L iduronidase, which is an autosomal recessive disease. Infants with Hurler's disease can be seen to have hepatomegaly, corneal clouding, and mental retardation. Histopathology shows a very characteristic balloon cell. These patients will die of cardiovascular complications. Hunter's disease is a milder form of the disease. It's a deficiency in iduronate sulfatase, and it's sex-linked. Much milder form of retardation and no corneal clouding present. Tay-Sachs disease is a deficiency in hexosaminidase A, which causes an accumulation of GM2 ganglioside in the neurons. Classic presentation for Tay-Sachs includes failure to thrive and a macular cherry red spot in an Ashkenazi Jewish child. So for Tay-Sachs, just think of the X. You have Tay-Sachs and hexosaminidase. For Gaucher's, this is a deficiency in beta-glucocerebrosidase. Glucocerebroside, as a result, accumulates in the brain, the spleen, the liver, and the bone marrow. This disease is typically diagnosed because of the cells. When you look at them under the microscope, they have very characteristic what they call crinkled paper cytoplasm. So a question here. A 3-year-old boy with mental retardation has hepatosplenomegaly. Analysis of tissue obtained on biopsy of the liver shows unusually large amounts of glucocerebroside. Which of the following enzymes is most likely to be deficient? Is it A, hormone-sensitive lipase, B, lipoprotein lipase, C, lysosomal hydrolase, D, sphingolipid synthase, or E, tissue phospholipase? The answer here is C, lysosomal hydrolase. It would be a little too easy if they called it beta-glucocerebrosidase, right? Because then that would be the obvious giveaway. So just remember that Gaucher's disease is a lysosomal storage disorder. Here we have some more diseases, Niemann-Pick disease and Fabry's disease. Niemann-Pick is a deficiency of sphingomyelinase. Causes the accumulation of sphingomyelin and cholesterol in parenchymal cells and tissues. Classic presentation similar to Tay-Sachs, cherry red spot, failure to thrive. Fabry's disease is a deficiency in alpha-galactosidase A. It's an X-linked inheritance. It results in the accumulation of globosides, and it ultimately results in renal and heart failure. So for these types of questions, what should you expect to see on the boards? It's going to give you a description or a picture of the child, and you have to make the diagnosis. Sometimes it will give you lab results. Same kind of thing. You have to know the diagnosis just from the description of the lab results. Once you know the diagnosis, the question asks for the missing enzyme, the product that accumulates, or the pathway affected. So you have to know those three things. What's the enzyme? What's the accumulating product? And or what's the pathway? Another thing that you might see is that they ask you, once you know the diagnosis, to describe or indicate the cell type or organelle affected. Or it could ask for genetic counseling for the parents. So here we have a few tips to help you remember some of these diseases. For Pompe's, remember the heart pumps blood. Pompe's is involved in heart problems, right? Muscles are there for arduous exercise, so think arduous, Ardles, McArdle's, affects the muscles. Another one is to remember that men go hunting but fabricate stories about the one that got away. So men indicating X-linked disease, Hunter's and Fabry's diseases, right? Another one, we went out picking cherries and filled our sacks. Remember that Niemann-Pick disease and Tay-Sachs disease are those that have the cherry red macula. And then remember the grocery bags are crinkled, grocery Gaucher's. Let's talk about lipid metabolism now, and familial hyperlipidemia type 1. This is an autosomal recessive disease. The mutations are either in lipoprotein lipase or ApoC2. Patients with familial hyperlipidemia type 1 have markedly elevated triglycerides due to increased chylomicrons with variable increase in cholesterol. There's no pronounced increase, however, in atherosclerotic disease. These patients symptomatically show eruptive xanthomas and acute pancreatitis, if their levels of triglycerides are greater than 1,000 milligrams per deciliter. Contrast this with familial hypercholesterolemia, which is an autosomal dominant condition with increased severity in homozygotes. This defect is in a different receptor. It's in the LDL receptor. The heterozygotes for this disease would be expected to have a 2 to 3-fold increase in cholesterol, causing tendinous xanthomas and early atherosclerosis. Homozygotes for this disease would have a 5 to 6-fold increase in cholesterol, causing severe pediatric atherosclerosis. So if a child comes into the ER having a heart attack, the first thing you're going to want to think about, familial hypercholesterolemia. There are also diseases associated with bilirubin metabolism. One of these diseases is Crigler-Najjar syndrome. This is a rare deficiency of the conjugating enzyme UGT1A1, or glucuronidase transferase. It's due to mutations in the coding sequence affecting the enzyme function, and this causes marked jaundice. Type 1 Crigler-Najjar is recessive and causes fatal kernicterus, where type 2, which is dominant, is less severe. Gilbert syndrome is a mutation in the UGT1A1 promoter region, so this causes a decrease in expression of the enzyme without altering its function. Gilbert's is more mild than Crigler-Najjar. You see mild scleral icterus with stress or fatigue. There is some clinical overlap with heterozygous missense mutations in UGT1A1. Overall, Gilbert's is an autosomal dominant disease with variable penetrance. So here we see a qualitative versus quantitative difference. In Crigler-Najjar, there's a problem with the quality of the enzyme. It's dysfunctional. It doesn't work like it's supposed to, and we see more severe disease. With Gilbert's, it's a quantitative issue. The enzyme structurally is fine. The problem is with the promoter, so we get decreased expression. But because the enzyme still works, we have less severe disease. Another type of defect associated with bilirubin metabolism is Dubin-Johnson syndrome. This is a defect in hepatic excretion of bilirubin glucuronides due to defects in multidrug resistance protein 2, or MRP2, causing benign fluctuating and right upper quadrant pain. This is a benign autosomal recessive condition. So here we see steps all along the way from unconjugated with Crigler-Najjar to conjugation defects with Gilbert's to more conjugated after hepatic metabolism with Dubin-Johnson syndrome. That concludes this section of the lecture. Next, we will discuss diseases of hematology, coagulation, and immunology.